Hello and welcome to another video. Today we are going to be talking about different musculoskeletal bone diseases. Now I chose these five specifically because I've been having so much trouble differentiating them all because they all sound so similar. So I've tried to come up with different ways to separate them mentally in my head and present it with lots of pictures and different analogies to try to hopefully make more sense of it all. And I hope it's helpful for you too. So I want to start off with osteogenesis imperfecta. So for this one, I think about imperfect because it's in the name. So I think of imperfect collagen. So osteogenesis imperfecta is an issue of imperfect collagen. And this is essentially what's going on here. So it's genetic. COL1A1 and COL1A2 is how I remember that. It sounds more like a name to me. It's autosomal dominant, and it's decreased collagen synthesis. So this is the collagen problem we're talking about, imperfect collagen. It's type 1 collagen, which is made up of a triple helix structure of 2 alpha 1 and 1 alpha 2 subunit. And there's two types. There's type 1 and type 2. So type 1 osteogenesis imperfecta is less severe. Why? Because you still have type 1 collagen, you just have less of it. Whereas your type 2 is very severe because the triple helix is completely absent. That is to say that you have no type 1 collagen. And so to the right, you see some of the most common symptoms like blue sclera, deformed teeth, and the brittle bones. The blue sclera, I think, is a little misunderstanding. Like the way they named it, I think is a little confusing because it's not that the sclera turns blue, it's more so the thinning of the sclera, and so you could see the vessels underneath and that kind of stuff. Before I move on to osteopetrosis, with osteogenesis imperfecta, the brittle bones. So what's going on there? Your type 1 collagen is what gives a little bit of the flexibility to your bones. So without it, the bones become very brittle. So if you think of it like a wooden ruler, if you were to bend it, it has a little bit of give before it snaps. In this case, there's no give. So the bones are weak in that sense where they fracture easily. They're very brittle. Next is osteopetrosis. Osteopetrosis, I think of atrocious. That's the word that comes to my mind. So I think of unopposed builders, right? So you'll get in a second, but it's essentially atrocious building, as I try to say that tongue twister. So think of it as continuously adding layers of asphalt over a damaged road without fixing the damage underneath. Okay, and I made a picture that I think is very beneficial on Gemini. So I think of it this way. A road, it's got a bunch of cracks and potholes and stuff. Instead of, fixing it, or just taking it all apart and repaving it, they're not fixing it. They're just throwing another layer of asphalt on top of that thing and leaving all the cracks and damage underneath. And over time, you're not fixing the problem, so you're just getting a thicker piece of road, right? But you still have all that damage at the foundation. And that's how I think of osteopetrosis, right? Osteopetrosis being a atrocious building. So you have the bone underneath that is, old, damaged, whatever. But your osteoclasts are not coming in to break it apart. But your osteoblasts are still functioning normally, so they're coming in and just adding more layers of new bone. So you have thicker bone, so you're adding mass, but there's not good structural integrity to the bone. So you have increased, uh, bone mass, but or density, but not strength. Um, and these are the three main genetic factors that play into osteopetrosis. CLCN1, I think of, because it has to do with proton and chloride. I think of Cl being chloride, and then I think of Chanel number 7 for some reason. I think that's like some kind of perfume or something. So a CLCN7, that is what plays a role with your proton chloride exchange pumps on your osteoclasts. And that's what's going to help keep the electrochemical gradient, so that you could pump all those protons in and keep the pit, what they call the pit, acidic, so that the osteoclast can function. Because when you're forming bone, right, your osteoblasts are laying down their osteoid, doing all that kind of stuff. They eventually form something called hydroxyapatite. Hydroxyapatite is essentially what your bones are made out of. In order to break that down, that hydroxyapatite, you need an acidic environment. So these are the different players that are helping to keep that environment acidic so your osteoclasts can function properly. Another genetic factor, I say it this way to try to remember, T-Surge1. That has to do again with your proton, but it's an ATPases time. And again, it's broken, so no acid. You need it to be acidic. And then this one specifically is associated with infantile malignant osteopetrosis, which is where you have severe leukopenia. It's like the worst out of the three. And then carbonic anhydrase has to do, again, with the proton, but it's another mechanism. It's a mechanism where your body converts carbon dioxide and water to bicarb and hydrogen. And again, you have no acid for your osteoclast to dissolve the bone. So osteoclasts cannot maintain this is wrong. Osteoclasts cannot maintain the acidic environment, that's what I meant to say, required to dissolve hydroxyapatite. Thus, the osteoblasts continue to build bone unopposed. So this is a typo, please remember. Osteoclasts cannot maintain the acidic environment required to dissolve hydroxyapatite. And then signs and symptoms with osteopetrosis. On the right, you see how the top right, the skull, it's more white than the one on the left. That more white X-ray, darker white, is showing that there's thicker bone there. There's more layers of bone, and you can actually see this. Something that they like to say, like on exams and stuff, is the patient comes in and they mention that their hat size has changed or their hat size has increased or something like that. And that's just because of the thickening of the skull, because of the added bone layers. And then on the bottom, the classic Erlenmeyer flask deformity on X-ray. Again, brittle bones here, similar to osteogenesis imperfecta. Remember, imperfecta, we're talking about imperfect collagen, different than osteopetrosis, which is more about atrocious. God, I can't say it back to back. Atrocious building, okay? And so that's where the brittle bones come in, because you're not fixing all the damaged layers underneath, you're just adding more bone on top. Now, these two other points I thought were interesting. So extramedullary hematopoiesis, and then you have pancytopenia, repeated infections, anemia. Why would you see that in a bone disease at surface level? It doesn't seem to have anything to do with those things. So the reasoning is pretty simple. You have so much of like this additional bone building, bone layering, that is taking up space in the bone marrow. And so then, of course, that's going to affect, red blood cell formation, white blood cell formation, all that kind of stuff. So that's why you see the pancytopenia. You may see repeated infections, because You don't have your white cells, um, anemia. We can't form as much red blood cells, and then of course the extramedullary hematopoiesis. Um, that can also manifest as splenomegaly, etc. Okay, osteomalacia is next. Osteomalacia, I think of the country Malaysia. It reminds me of that. And osteomalacia is a condition that has to do with deficiencies in like minerals and vitamins. So I try to think of the country of Malaysia, and I try to think of, for some reason, the country is just struggling with, vitamin deficiency and mineral deficiency. Maybe it's just like a problem with like food source or something like that. For some reason, my mind just goes there. And that's what makes me think of osteomalacia. So this is mineral loss. So you want to think about bone loss because of mineral deficiencies. So it's not necessarily that your osteoblasts or your osteoclasts are not working right. It's just you don't have the resources, or you don't have the minerals that you need to build the bone. So I think it's easier to understand if we go through how is bone even formed, because I feel like we've been talking about it, but we haven't dived in. So osteoblasts lay down something called osteoid. Osteoid then works with calcium and phosphorus, and that gets converted into hydroxyapatite. This is also a typo. I switched them by mistake. I got confused. But so osteoid will work with the calcium and the phosphate to convert to create hydroxyapatite in an alkaline environment, not an acidic one. So remember, alkaline environment is where you build bone. An acidic environment is where you break down bone. And I just think of that like, in my mind, acidic, I think of like the typical cartoon of like bubbling acid, and it just like, dissolves everything it touches. So an acidic environment is going to be to break down that hydroxyapatite, to break down the bone, whereas an alkaline environment is going to be to build up the bone. And of course, that balance, like we spoke about before, has a lot to do with those different genes, your CLCN7, your TSURG1, carbonic anhydrase, all that kind of stuff. This is another image I made with Google Gemini that I think is great. So here on the left, you see your osteoblast building bone by laying down that osteoid matrix. You have your mineral deposition of calcium and phosphate to form the hydroxyapatite crystals in a alkaline environment, right? That's happening in alkaline environment, right? Blue alkaline, and then red acidic over here to the right, your bone resorption, their osteoclast activity. They're breaking down bone, they're dissolving all the minerals and all that kind of stuff by releasing acid and enzymes. So in an acidic environment, your osteoclasts are going to be dissolving hydroxyapatite, and then that of course is going to release calcium and phosphate, and that's essentially what goes on. Then in the center, you have a little bit more of like the specific biochem, where you have rank L and your OPG. Okay, the simplest way I can think of explaining this is rank L is going to be what's going to activate your osteoclasts, and OPG is what's going to work to activate your osteoblasts. Okay, so they are essentially the same thing. They just have different. They have like different responses, and they function with different. Sorry, maybe that's confusing, but I'm just trying to say rank L activates osteoclast, OPG activates osteoblast. That's essentially what it is. So osteomalacia, normal bone mass but decreased mineralization. So you can have deficiencies in vitamin D, calcium, phosphate. Probably vitamin D may be the most common, I would say, because you can have patients that can't absorb vitamin D, or they can't They have chronic kidney disease. They can't make the vitamin D hormone and that kind of stuff. Or people that are not getting enough sun, or people that don't get it from their diet, stuff like that. And then of course you could say the same about calcium. That's why in the U.S. there's so many things that are fortified with calcium and vitamin D, different milks and cheeses, and then phosphate. So let's say, for example, you're deficient in vitamin D. The way your body's going to respond is it's going to activate your osteoclasts to start breaking down bone to release the calcium in the bone. And then, of course, when they do that, they're also releasing phosphate. So that you can have more calcium circulating throughout the body, so you can use it for many different things. The result of that is elevated parathyroid hormone, which is where you get the secondary hyperparathyroidism. Your vitamin D level, in this case is low. Your calcium may be a little low, but it may be normal, right? Especially like towards the very beginning of all this, because your body's trying to compensate. Your phosphate's going to be low though, because your body's going to get rid of all that phosphate that's coming out of the bone that is breaking down, and it's going to pee it out. So you're going to have high phosphate levels in urine, but they're going to be low in the blood. And on labs, you'll also see elevated alkaline phosphate. Although not specific to osteomalacia, it's a very high yield lab marker. The reason is because alkaline phosphate is what your osteoblast is going to release to create that alkaline environment to build bone. So your osteoblasts are trying to build bone, but they don't have enough, calcium and phosphate or vitamin D, all these things, all the minerals needed to build the bone. So your body's like, shoot, your body recognizes there's not enough bone, we need to build more. So it's trying to upregulate that through your osteoblasts, and thus the elevated alkaline phosphate. And so these are also some findings that you could see in osteomalacia. Craniotabes is the thinning of the bone or the skull, and that's simply because your osteoclasts are going absolutely haywire trying to get their calcium, and they're trying to get minerals. Your body's trying to get the minerals it needs, so it's just breaking down the bone. Frontal bossing, I think of, for some reason, I just think of Minecraft head, like a box head, because that could be a sign. Not sure how to pronounce this. Rachitic or rachitic. It's probably rachitic. Rosary. That is essentially these bony bead-like things that appear in the chest that kind of look like a rosary, and then the pigeon chest is that chest deformity where your chest is kind of sticking outward. And then osteomyelitis, second to last, right? Bone disease that we're going to be talking about. This one I think is probably the easiest to remember because of the itis at the end. It's some kind of infection. So this is essentially a bone infection. So that's how you want to think about it. And there's different types. It's most common Staph aureus. That's the most common bacteria because it's all over your skin. It's just very common for that to be the culprit. But you have the basically blood infected or exogenous version, which is just through trauma. With kids, it's common to see in the metaphysis or the epiphysis. The reason is because that's where a lot of the bone growth is going on in kids, and so there's a lot of vasculature there because of that. And the blood also slows down there. So it gives the bacteria more time to drop off and infect the bone. Adults, the vertebrae, because a lot of vasculature, vessels or blood flows a little slower there, kind of the same reasons. And then your IV drug users, the sternoclavicular and the pelvic bones. This is interesting. With sickle cell patients, you're thinking of salmonella infections or E. coli as the most common. And I didn't realize this, but the reason is because obviously with the sickle cell patient, you have the sickling of the red blood cells, and that could cause the vaso-occlusive crisis and all that kind of stuff. But in those smaller vessels, right, it could clog up the vessels and cause issues. And in the gut, it's actually common in the gut and, to have these issues. That's going to affect the blood flow, right, that you're getting there, thus affecting all the nutrient absorption, immune system. And so the most common bacteria in the gut is Salmonella and E. coli. So that barrier can be damaged because of the lack of blood supply, and you can easily get Salmonella or E. coli that can eventually lead to a osteomyelitis. With an IV drug user or a puncture wound, you're thinking Pseudomonas, and then with immunocompromised, you're thinking the Mycobacterium. And then there's an acute and a chronic. So the chronic is the picture on the right. That's called a Brody abscess. And then with the acute is first the necrosis of the bone, which is what they call the sequestrum formation. So your body, to try and keep the infection in one place, keep it from spreading, is going to form what's called a sequestrum, which is basically a layer of like it's trying to wall it off with bone. So that area of necrosis is what they call the sequestrum, the dead bone. And then the involucrum forms around it to try and box in the infection, keep it from spreading all over the place. And so that's what happens acutely. Chronically, however, you let that process play out, and then you have what's called a Brody abscess, which is essentially an abscess in your bone just full of pus and infection stuff that your body just kind of walled off and kept there. And then finally and lastly, osteoporosis. It's in the name, I think, of porous bone. And this one, as you see to the right, one is more porous than the other. But this has a lot to do. I mean, there's so many things that can cause this, but the most common is definitely estrogen depletion and then chronic steroid use. So you see this a lot in women post-menopause. There's decreased bone mass, but normal mineralization. So there's no issues with your minerals. You're not deficient. You just have less bone mass because, in the case of post-menopause, the estrogen depletion. And the way that works is low estrogen leads to increased inflammatory markers. So think of TNF-alpha, IL-1, IL-6, all that kind of stuff. That's going to lead to, that's misspelled, it's supposed to say rank L being upregulated and OPG being downregulated. Remember, rank L is activating your osteoclast, OPG is regulating osteoblast. So your rank L is upregulated. That means your osteoclasts are going to start breaking down a lot of bone, and your OPG is downregulated. So that's going to further inhibit your osteoblast. And so, of course, that leads to osteoclasts working relentlessly. And then your chronic steroid use is also a common risk factor that also activates rank L. So you're not supposed to be taking like steroid injections, for example. Like if you have maybe a knee injury, you have a lot of pain, and they do steroid injections for that. There's a lot of risk with chronic use. And then lastly, some findings for osteoporosis. So your DEXA T score, anything less than that is definitive diagnosis. Fragility fractures are also a definitive diagnosis. So, your typical, grandma got a hip fracture, falling from standing height, you're thinking osteoporosis, or she bumped into something and got a fracture. And then very common, of course, the stooped posture, your back pain, because of the bone breakdown. And that's it. Hopefully this was helpful in trying to differentiate all of these bone diseases, because for me, it was definitely hard. But yeah, that's all I have for you guys today. Thanks for watching.